All right, constipation. So constipation is very common in America. We like to sit down a lot. We like to do our TikTok, and we like to be, again, need a PT, OT, speech language therapy consult after our bowel sessions. So that can contribute to chronic constipation, but there's different types of poops. So we're talking about the type 1 to 3 poops, right? Type 1 to 3 poops are on your Bristol scale, right? So Bristol is how we measure, not measure, but quantify, not really quantify, but describe our poops, right? They can be little nuggets, they can be nuggets with friends, or they can be pretty cracked, or they can be a normal poop, which is type 4. That's the one you want to love, right? That is the one that everybody should be at. They should be having a quality BMQ 24 hours. That is normal. If you're going to the hospital setting, you're probably be more than 24 hours, be 48 hours. And it's more than 48 hours, it's time to initiate a BM regimen, right? Especially the ICU might even do a prophylactic BM regimen, right? With prophylaxis with a couple agents to avoid any kind of constipation that may develop. And so we're a little bit ahead of the game, okay? So we'll talk about BMs and constipation in a little more detail. And we'll talk about acute abdomens. That's when you have an abdomen that has perf, or an abdomen that is painful, right? Is a abdomen that is acutely developed, and it could be diverticulitis, it could be appendicitis, it could be pancreatitis, it could be a perforation, it could be many, many things. So we'll talk about that. Usually you break your quadrants down into 4 sections, right? And you look to, or even you can do 6 sections if you're fancy, or is it 9 sections? You do like epigastric, periumbilical, and you could do your flanks as well. So you have your left flank, and your right flank, and you have your periumbilical, and you have your right upper quadrant. You could get really detailed with this. Okay, so then we'll talk about small bowel obstructions and large bowel obstructions and what the difference is there. But they all end up with a lack of forward movement of bowels, right? So, oh boy, here we go. So constipation causes. So what causes constipation? Decreased peristalsis, decreased movement through the bowels, right? And or there's which will increase your transit time, and then you will absorb more water. So these are going to be much more nuggety, right? You're going to start absorbing a lot of water, all right, into the serum, which is great, but not so much for the constipation. So that's going to make it much more difficult to have a bowel movement overall. Okay, there are different types of reasons why this might happen. It might be something mechanical, it might be a stricture in the way. There might be something that's compressing the bowel. There might be adhesions in the bowel that are, when they have post-op, when you have a surgery, I think it's like 10-15% chance of having a bowel obstruction. Again, when you have a bowel surgery of any type, when they've opened up your bowel and touched it and they put it back together, you can have adhesions to the bowel wall or the abdominal wall, and that can cause an ileus to form, right? Or it's technically mechanical obstruction, right? So the metabolic reasons, hypercalcemia is known to cause decreased peristalsis of the bowel. There's endocrine reasons like hypothyroidism, where everything kind of slows down. That's going to cause slowage down of our peristalsis and therefore constipation, right? There's infiltrative processes that can interrupt peristalsis like scleroderma and such. There's pelvic floor issues. There's IBS. IBS has 2 varieties, constipation and diarrhea variety. They're denoted by the C or the D at the end of IBS. Now, it's not inflammatory bowel syndrome. It is what? It is irritable bowel syndrome, right? You usually have like clear-cut diagnosis. You usually have to have it over a certain amount of weeks or months, and certain, the Bristol chart has to be, they have to meet all these different steps to say you have constipation that's chronic from IBS. And drugs. So popular drugs being like opioids, right? Anticholinergics can do it, antihistamines can do it. These are all things that are going to slow down transit and make us at risk for constipation. And of course, a secondary reason, it wasn't just the bowel's fault, it was our fault. It was something that we introduced, or whether it be diabetes or be analgesics or opiates and anticholinergics like we mentioned, but it could be a low fiber, sedentary, dehydrated lifestyle. Right now, everybody in America is drinking all their waters. Some people overdo it. They'll bring a 2-gallon jug with them to the gym, right? A 2-gallon jug to them to work. They got their big, got the little trash can, a 35-gallon trash can, and I'm ready to sip out of this, bad boy, right? Sure, all right, that they're not going to have constipation, but someone, you see other nurses that don't bring the whole, they're not drinking a drop the whole shift. Okay, so how do you know someone has Diarrhea, there's all kinds of things we can do. We can do a barium swallow to see if there's something like physically blocking the flow, right? It lights up the bowels and you can see that there is a physical blockage somewhere along the route to the anus. Or there's a colonic transit study, which I don't know, it's a special breed of people that can do colonic transit study. They have to sit there, you have to go into a room, it's like a room, there's like a spotlight on this bedpan, and you have to, then there's like an x-ray there, and then it takes pictures of you as you defecate. It's defecatography, right? So it's where they go in there and they take a picture of you defecating, not like through x-rays, right? So it's like they're going to be looking at saying, hey, is there a problem with the physical act of defecation? Right, and it involves some unique tools that looks like a torture device, right? As you'll see right here. So here's an example of a defecatography gun, right? So they go in there. It does look like a cock gun, right? So it's going to be in there to inject some fluid, paste, right? And it's going to light up and they're going to be able to see if there's a problem. Okay, so it is a way to see if there is any kind of abnormal constipation, or abnormal movement or transit along the GI tract. I can't make this up. All right, so different agents we can use for constipation. So you figured out what it is, right? So you went to this event and you found out what was going on. So what can you do? So things you can do are, you can order Colace, right? So Colace, get an order for Colace. It's the same thing as, can I have another? And you just throw it in the trash. It's exactly the same thing, right? Colace has no efficacy in the hospital setting. Outside the hospital setting, sure, it might work, right? But has no effect in the hospital setting, right? We've known that since the year 2000. Year 2000 has no evidence of working in the hospital setting. It's more pill burden. It does not work on patients that are hospitalized. So just throw it away. Don't even worry about it. It's like, oh, you got a bowel protocol? Oh yeah, we're on Colace. It's like, no, I just ignore that completely. They might say Senna with Colace or Senna with Docosate. Sure, you can tag along. That's fine, right? But Senna, that's a good one, right? Senna is down here. It's a stimulant of the GI tract. It's going to increase colonic secretions and make things start moving along, right? Dulcolax, that's usually given per rectum. All right, that's definitely going to make things move, right? So it's a suppository that's given, and it's going to then provide a definite stimulus to defecation, right? But Senna is usually our go-to agent. We'll usually start Senna first on patients, and it might even be on something like our old friend PEG, right? So Miralax and Senna is usually our go-to bread and butter that we're going to use to get some bread and butter out of the patient, right? So we're going to have our bowel protocol is going to be Senna and Miralax is usually the go-to baseline agents that we have. You might start it prophylactically on someone that's in the ICU, someone that's post-spinal surgery, someone that is bedbound. It might just be already on Senna Miralax just by default. We can always hold it if they have excess BMs. And what is excessive BMs? What is too many? That's more than how many? 3, right? 3 or more than 3 BMs in a day, that's considered it's time to hold your agents that are causing BMs, right? If it's less than 3, that's fine, right? I bet everybody in this room has gone BM twice in one day without diarrhea, right? So especially if you have an increased caffeine intake, right? This could definitely cause some more motility action. All right, so on the outpatient side, they might load up with some bulk forming agents. If they have low fiber diets, they're going to provide the fiber in the source of psyllium or methylcellulose. These are things that are going to add bulk, and if you add bulk, that adds water. And you add water and bulk, that's going to distend the bowel, and then the bowel is going to contract in turn, just like our heart. If you fill up your heart with fluid, it has a Frank-Starling law, and it's going to compress and eject fluid. So in this case, it's not fluid, it is BMs, right? So we're going to have a more peristalsis with more bulk-forming agents. This actually is one of the recommendations for IBS with constipation. Lactulose is on our list here. Lactulose does not get absorbed. It's just a sugar, right? Just like PEG is polyethylene glycol. That's also a sugar that is going to not be absorbed, right? Doesn't get absorbed into the from the GI tract into the serum and the bloodstream. So therefore, if it stays there, it's osmotically active. It's going to pull fluid from the gut or from the gut blood supply into the bowel. So we're going to get water into the gut, and therefore we're going to get more volume and therefore more peristalsis, right? So lactulose is an option. Lactulose is also a jet fuel, but it's a fuel for bacteria, and bacteria love to produce what? They love to produce gas. That's the only way you get gas in life, right? Flatus, farts are only from bacteria, right? And everybody has their own milieu of bacteria. Everybody has their own bacteria that they produce in their own amounts. So everybody's fart is unique, right? You can identify someone off a fart thumbprint, right, or fingerprint. It is a very, very unique scent, right, or brand. So that is the idea behind farts. All right, so you have to know more farts you ever want to know about. So we got milk of magnesia, all right? So milk of mag or MOM. So this has mag in it, so and that can get abnormally absorbed, right? Especially if someone has renal failure. So it's usually not standard ICU bowel protocols or bowel protocols. It's if the renals check out, then yeah, you can give milk of mag. That'd be fine. Same thing with mag citrate. When we talk about mag citrate, does it get absorbed? It's going to cause a lot of activity. All right, that's what we gave at the end of colonoscopies to make sure they absolutely go and clear out the bowels. All right, and then if none of that stuff works, we can then start them on enemas. Right, so enemas are going to be our agents that we give once everything else has failed, and then they're only given per rectum. We have tap water, soap suds. Soap suds are going to increase activity. They directly stimulate the peristalsis, right? And then mineral oils can help add not moisture, but lubrication to those crusty stools. And then we got molasses. I've never seen a molasses enema. I don't know. Milk and molasses. That might be a homebrew. But then we definitely have Fleet's enemas. Fleet's enemas have phos in it, and patients with renal failure don't like phosphorus. So there's caution with renal failure if we're doing Fleet's enemas. But usually tap water, soap suds enemas are the classic ones we do in the hospital setting. And then we have other secretory drugs, not secret drugs, but secretory drugs, drugs that may help the bowels secrete chloride and therefore water will follow. And these are usually used for IBS. So the IBS might be a lubiprostone or linaclotide. Linzess is the brand name. These are going to help stimulate peristalsis directly and also help secrete more items into the GI tract to help it along, right? And then we have patients that might get backed up or constipated when they have opiate use, right? If they take opiates chronically, on the outpatient side, they won't prescribe this. I think it's like 10 days or two weeks. I forget what exact, I think it's 2 weeks of opiates, and they don't have those, no bowel movement for 3 days, then they might give methyl naltrexone, or Relistor is the brand name, right? So Relistor is the brand name. And in the ICU, definitely if your patient's on a fentanyl drip, right? Fentanyl infusion, Dilaudid infusion, morphine infusion, they all cause constipation, right? That's one of our significant side effects, and we have to be alert to when the last bowel movement was. If they're on fentanyl infusion, they probably should be on like Miralax or Senna as a baseline just to prevent the constipation in the first place. We don't want like 4 days to go by, oh, they haven't had a bowel movement yet. We should have something prophylactic already on board, so Senna and Miralax, right? So that's the idea with a bowel protocol, is to make sure that we have things on prophylactically, but also be alert to quality BMs. We want to make sure we have a quality BM every 2 days at least, right? Maybe 3 days is pushing it, but definitely every 1 to 2 days has a quality BM, right? And quality means a Bristol stool score of 4, right? A 1 or 2 or 3 is not quality. They need to have some more activity, right? And if they have no activity, we're going to increase our bowel protocol from Senna Miralax to add lactulose to add some other stuff on top. Okay, so that's where we're going next. Those are our bowel protocols that we need to initiate, and it's going to use a combination of these drugs. Okay, so our ICU bowel regimen. What kind of BM do we want? Quality work. We want a quality BM, right? So what does Drake want? He wants a sausage-like, snake-like, smooth, and soft BM, right? That is what we want. If we are 1, 2, or 3, that is not great. If we are 4, 5, 6, 7, That's also not great. That's the other end, and that can cause some more problems in of itself. All right, so type 1, that's our little hard lumps, right? We have little nuts, little nuggets, right? Really, really hard to pass. Whereas if we have some, very, very lumpy stool, that's not what we want as well. We want a nice sausage-like smooth stool, not one that's cracked, right? With cracks in the surface. That's way too dry. It's been in the bowel for too long, and the large bowel has absorbed way too much water. Right? So quality BM every 24 hours, right? 83% of patients develop constipation. If you're constipated, that's going to increase your length of stay and your vent days, right? So someone's like, they're doing an SPT in the morning and you're like trying to wean them, like, you got this. And they're super agitated because they're backed up. They don't feel good. They might have some belly pain and they don't feel good, and they're going to cause them to be on the vent one more day because they start getting tachycardic and tachypnic. And little did we know it was because they hadn't pooped, right? Also increase, bowel load or increased stool burden can also cause a increased abdominal pressure, which can translate to increased intrathoracic pressure, and that's not going to help our volumes as such. All right, so early administration of laxatives can prevent constipation. So laxatives / cathartics, that's another name for something that's going to make you poop. Right. So again, our goal is to prevent constipation, and really 48 hours is what we want. We want no more than 2 days to elapse before we have a stool, we want to have a stool every 1 to 2 days, basically, right? So initial steps, how you do a bowel protocol, you got to make sure the gut's functioning, right? You can't be adding all this stuff and then their guts doesn't work in the first place, right? So the gut has to be working. We want enteral feeding because if there's no food in the gut, there's no poop in the butt. I make that, okay, now I'm rhyming. All right, so we want to make sure that they have to have something to have something come out, right? So having food is going to be one of the first steps, right? So doing enteral feedings at what kind of rate? At a trickle, right? So you just trickle the bowel to make it, you just tickle it, right? You're just tickling it so that there's at least some feeding. And what's that rate look like? Like 10 mLs an hour. That's all we need for the first day or two. After that, we can start escalating to 20 mLs or 30 mLs an hour, or 40, whatever the goal might be. All right, determine if they're a high-risk patient, so they might even be on a prophylactic regimen. Prophylactic regimen is our step 1, step 2. Step 1 being Senna, and then Miralax, right? So Senna and Miralax, there's the doses there. You have this, I'll print this out for you as well. I don't think it's anywhere else, but we can definitely post it in maybe the bathroom. I think it was in the bathroom. Is it in the bathroom right now? Yeah, so you may have seen this before. All right, I put it in the bathroom just so you're aware of it. All right, so yeah, so we have Senna, Miralax. All right, those usually could be prophylactic. So this could be a prophylactic dose right here. So PPX for prophylaxis if you have a high-risk patient. All right, so how do you know you need to be on prophylaxis? The first how do you know you need to be there? First of all, if you have hard stools, like a Bristol 1, right? Bristol 1 is their little nuggets, little nuts, right? How do you know what if they're backed up and they have hard stool to begin with? We might have to do a manual disimpaction to make sure there's not something in the way in the first place, right? Because if you can send in Miralax and all this stuff, they might just have a plug, and we have to take that out, right? If they have diarrhea and they haven't had a stool, diarrhea could also mean worst case scenario an impaction as well, right? So every day we escalate from step 1 to step 2 to step 3 all the way to step 5, right? So what's after Senna and Miralax? That's going to be our lactulose, right? Or it's kind of like Miralax where it's going to pull water into the bowel, and hopefully they have results. And then if that doesn't work, they don't have results, then what comes next? That's going to be bisacodyl or Dulcolax, right? So Dulcolax or bisacodyl, these is given per rectum. We're not going to give them more than 3 times per week. Sometimes you have some nurses give it twice in a day. That's a lot. So it should be about 3 times a week. And this is really for someone who's really not had that bowel movement. We might escalate this protocol faster, right? Usually it's day 1, day 2, day 3, day 4, day 5, and that's 5 days without bowel movement. And we know that 3 days is pretty much the borderline where we should not be having. We should definitely have some results. But if Dulcolax does not work, and it usually does work, the next step is what? Is a enema, right? So an enema is next, right? So show me a loose dookie or a loose bowel or else, right? Or evacuate. So show me large dookie or else. So Senna, Miralax, lactulose, bisacodyl, enema, right? What's the enema? It's going to be, it's really your choice. But soap suds or fleets, tap, mineral oil, they can happen. Which one is renal failure not great with? Renal failure is not recommended for who? For our fleets enema, right? So caution in renal failure. with AKI, CKD, etc. Right? So after that, then they've had relief of their constipation, or sorry, they have a what are things we can do in the meantime? Doing a KUB is a good idea to make sure there's not any kind of ileus forming, right? We might have to do manual disimpaction. We have to make sure there's no rectal tube in place. Even if they have like diarrhea, the diarrhea could be from an impaction, right? So bowel protocol will then be resumed about 48 hours after that. And of course, if they're high risk, we might start it ahead of time. All right, so again, our goal is a quality BM within a Bristol 4 within 48 hours, right? Smooth, soft, and snake-like. If they have a lot of stools, then we'll back off on the protocol. We can just start clean, we can start fresh with nothing, and then we can keep adding as the days go on, right? So what do? We're going to do right down here, we've got results there, but we're going to have right here, we're going to give Senna first, right? We're going to give Miralax next. What's next? We're going to have some lactulose, right? Still not working. We're going to bisacodyl, right? And then we're going to do an enema. We've got little nuggets there. And then we'll have results, right? So it's show me loose bowels and evacuate. I like the one show me large dookie or else, right? Because or else is the enema, okay? And you want to make sure we have good quality BM every how often? Every 24 to 48 hours.